Every year, women in South Sudan die in childbirth from entirely preventable causes. South Sudan carries one of the world's highest maternal mortality rates, a crisis that has been aggravated by decades of civil conflict. That's from SAMI in 2020. And while international attention tends to frame this as a story about missing resources, not enough hospitals, not enough staff, not enough medicine, etc., that framing misses the point entirely. This essay argues something more uncomfortable. The underutilization of maternal health care infrastructure in South Sudan is driven not by a simple absence of medical resources, but by the structural violence and over reliance on humanitarian aid models that were never designed to heal. That is from Farmer in 2006. The buildings exist, the clinics are there, the system is broken anyway, and that is not by accident. To understand the weight of this problem, consider the numbers. According to the UNFPA, South Sudan's maternal mortality ratio stands at approximately 1,150 deaths per 100,000 live births, among the worst on earth. Only 19% of births are attended by a skilled health worker. The country has roughly one doctor in 65,000 people and one midwife per 39,000 women. Research conducted by SAMI and colleagues in 2020 in Upper Nile and Unity states, two of South Sudan's most conflict-afflicted regions, found that maternal and child health services were almost entirely dependent on international NGOs operating in emergency mode with minimal integration into a functioning national health system. That is from SAMI in 2020. Facilities existed, training staff arrived, women still died. The question this essay asks is not where the resources went, it's why the system as currently designed cannot deliver care to the women who need it most. To answer that question, we need the right framework. That framework is structural violence. Paul Farmer and colleagues define structural violence as the social arrangements, economic, political, legal, and cultural, that puts individuals and populations in harm's way. These arrangements are structural because they are embedded in the political and economic organization of our social world. They are violent because they cause injury to people, typically those who bear no responsibility in the inequalities that endanger them, as from Farmer in 2006. Crucially, Farmer argues that structural violence is normalized by stable institutions and regular experience, becomes so ordinary that it appears almost invisible, embedded in what he calls ubiquitous social structures. That is from Farmer in 2006. In global health, this invisibility is dangerous. When clinicians and policymakers fail to account for history and social structure in their analysis of illness, Farmer argues that, and I want to be precise here, structural violence is perpetrated through analytic omission. That is from Farmer in 2006 again. That phrase should stop us in our tracks because in South Sudan, the dominant global health response has been built almost entirely on that omission, treating a structural crisis as a logistics problem. This essay identifies three specific mechanisms through which structural violence operates in South Sudan's maternal health system. The first is unstable funding and the fragmentation of care through humanitarian aid dependency. The second is socioeconomic discrimination at the point of care. The third is the exclusion of local communities from policy planning, and together they form the architecture of a system that fails women not despite its design, but because of it. Mechanism is what James Pfeiffer, writing about Mozambique, describes as fragmentation that results when donor funding bypasses government ministries and flows directly through international NGOs. That is from Pfeiffer in 2003. Pfeiffer argues this model, however well-intentioned, created parallel structures that compete with national infrastructure rather than strengthening it. Once again from Pfeiffer in 2003. The South Sudan case is Pfeiffer's Mozambique amplified by war. NGOs have delivered over 80% of available healthcare for years, but when a funding cycle ends, programs collapse. When an NGO leaves a district, the services it ran simply disappear. Pfeiffer documents how government healthcare workers were systematically pulled out of the healthcare public system by NGO salary offers, leaving public facilities hollow. Once again from Pfeiffer 2003. What makes the structural violence, not just poor planning, is that the NGO model operates on short-term project logic. Aid is designed to respond to emergencies, and in South Sudan, it becomes the permanent replacement for a healthcare system that was never allowed to develop. The second mechanism operates closer to the ground. Research by Bio and colleagues in 2020 found that healthcare workers in Torit County, South Sudan were making stigmatizing remarks about women who arrived in facilities and worn their dirty clothing. Women described being shamed to turn away the very moment they were most vulnerable. That is from Bio in 2020. This is what Alan Goodman calls racism, not biological, but institutional. A system in which certain human beings are treated as less deserving of care based on their social position. That's from Goodman in 2016. The consequences cascade. When a woman walks hours to reach a clinic and is humiliated, she doesn't come back. And when she tells other women, they don't come either. What global health programs diagnose as a problem of individual behavior is, in many cases, a rational response to structural harm. That's from Farmer in 2006 and Bio in 2020. And as Oni Orasan's work in Nigeria shows, the women who are turned away or die are often simply not counted. Deaths excluded from data because recording them would reflect badly on the facility. That's from Oni Orasan 2016. When women like Blessing disappear from the data, the conditions that killed them disappear too. The third mechanism is perhaps the most systematic. Belade and colleagues in 2022 analysis of South Sudan's Boma Health Initiative found that community participation was largely performative. Communities were consulted, but priorities identified by local people were routinely overridden by donors and government officials far removed from the women they served, as Belade in 2022. This exclusion is not procedural, it is about who gets to know and understand things. Oni Orasan shows how dependence on numerical metrics creates perverse incentives to produce data that shows program success, regardless of whether the success is real. That is from Ori Orasan in 2016. Community knowledge doesn't translate into donor-readable metrics, so it gets left out. And as Farmer would put it, the result is structural violence perpetrated through an analytic omission. That is from Farmer in 2006. When programs fail, the failure gets blamed on individual behavior or cultural resistance, never on the design of the system itself. The emergency care paradigm governing South Sudan has saved individual lives and failed women systematically. As Sammy and colleagues found it unintentionally perpetrates health inequities because it is built for crisis response, not sustainable care. That's from Sammy in 2020. It burns out the workers inside it from Stromer in 2018 and Surya in 2017, reproduces donor-centric logics regardless of who runs it from Gong in 2022, and leaves behind no infrastructure when funding ends. The alternative is documented, not utopian. Farmer's PIH model shows that when structural barriers are removed alongside clinical ones, disparities in health outcomes largely disappear. That's from Farmer 2006. Belade and colleagues demonstrate that genuine community co-design, not consultation but co-authorship, is the prerequisite for systems communities will actually use. That is Belade in 2022. As Kidler captures it, a preferential option for the poor demands not equal access but prioritize access. The most structurally disadvantaged go to the front of the line. That is Kidler in 2003. In South Sudan, the inverse is currently true. South Sudan's maternal mortality crisis is not a mystery. We have the scholarship to name what kills women. Farmer gives us structural violence. Pfeiffer shows us how NGO fragmentation hollows out national systems. Bayo shows us discrimination waiting at clinic doors. Ani Orasan shows us how the deaths that result get quickly removed from the count. The underutilization of maternal health care infrastructure in South Sudan is driven by structural violence and over-reliance on humanitarian aid models, not by a simple absence of resources. True structural healing requires dismantling aid dependency, confronting discrimination at the point of care, and co-designing community-led systems with the people that they are meant to serve. That is from Farmer in 2006, Belade in 2022, and Sammy in 2020. The notice has been served. The question is whether global health will respond. Thank you. Have a great day.